It is shocking, Dr. Meakin, how many patients that are calling our office that are in their 30s with stage 4 colorectal cancer. It's just shocking to me.
My son is in his 30s and my daughter in her late 20s. They have friends that have had cancer. I never had that.
Neither did I. How do we help these patients navigate so they have a chance to not only survive, but thrive?
We'll help people align to do what they truly want to do, help people with tools in sort of a supportive way.
Repurposed medications, what exactly is that?
They say about 1/4 to 1/3 of the prescriptions of these vast array of drugs are for things that the FDA didn't initially approve for.
Right.
Over time, certain side effects of commonly used drugs were identified, and sometimes those side effects are good effects. The poison is in the dose. So it's all about getting that dose right in that sweet spot.
Were you seeing good results with that?
Well,
Welcome to Rethink My Health Radio show and podcast, where each week we come to educate you about healthcare matters that matter most to you, your family, your loved ones. And as I say time and time again, they really do matter to us, the research scientists, the physicians, the practitioners in the trenches, talking and working day in, day out, helping our patients combat chronic disease. Welcome to our first-time listeners. My name is Dr. Gez Agolli. I'm going to be your host. As we're going through a series on chronic diseases and getting to the root cause and giving you recommendations, I just want to give you this disclaimer that this show is about education. It's about wellness. It's not here to replace your physician's advice. We encourage you to work in a collaborative way with your doctors and practitioners, and we just want to inspire you. We want to galvanize you to take action. I'm really excited about this show today because we've done several shows with Dr. Burdett, Dr. Pete, a couple of patients, talking about cancer. Cancer's on the rise. Unfortunately, according to the CDC, NIH, our numbers are continuing to rise. Well over 2.1 million Americans are going to be diagnosed this year alone. So we need some more information. We need some forward thinkers out there. We need more answers. We need our population, our American citizens, to understand that, yes, scientists are working hard and physicians are working hard, but we have some amazing medications and treatments already. And this is what we're going to talk about in combat today. I'm excited to interview one of my guests, Dr. Charles Meakin, board-certified oncologist. He is a forward thinker. He's been practicing for several decades. He's come up with some very unique approaches. And Dr. Meakin, first of all, thank you so much for joining me this morning. It's great having you here.
Sure, Dr. Gez. I'm all about education, and thank you for the audience to speak to that. Thank you.
Oh, absolutely. And, what's interesting, Dr. Meakin, over the past years, a lot of patients, not to be too critical, but they're always looking for something called, I'm looking for the cure. And you and I both know that cancer is a multifactorial disease, but I want to take it back a little bit. You've had a very long, respected career as a conventional oncologist. Can you take us back from the beginning? What originally inspired you to become an oncologist?
Yeah, as I think about that, I would say it goes back to my childhood. I was fortunate to grow up in a very healthy, large family, Catholic environment in Cincinnati, Ohio. My first thoughts were to be a priest, to have good mentors in that area, and kind of did the Catholic school, high school, college program. And then my father was such a powerful, positive figure in my life, and I couldn't conceive of not being a father at some point. So I opted for what I looked at the time to be another giving and healing art, and that was to be a physician. And so as I went through med school, and I always studied. I was the weird kid who did martial arts for a long time, starting in high school. I also studied Eastern philosophies, yoga, meditation before anybody talked about that. And ultimately I thought, well, oncology will be the perfect sort of, arena to best study how the physical, the mental, and the spiritual sort of deal with a disease. It wasn't superficial when you get cancer. And that's what steered me in med school to choose oncology. I chose radiation oncology because, as I said originally, I thought about surgical oncology and medical oncology. Back then, medical oncology had, you made a lot of people sick in the hospital. It's much better today. So radiation oncology looked like a field where I could still be have a family and work hard. And that's where I went. I was fortunate to go to Stanford, where they had a very rich culture of, surgical oncology, medical oncology, radiation oncology, working as a team. And, I learned the essentials of that. And then over my career, I started looking at what are we missing here? We're missing, some dedication to correcting lifestyle, to instilling a mindset, to shed past baggage, to re-identify our personal why as we sort of manage a challenging disease. And so that led me to where I am today.
Well, that's interesting. It's interesting you talk about radiation oncology, and you've seen a major shift. There's been some tremendous advancements with radiation oncology, a little more precision, right? I know at the beginning it was a little more challenging. I remember one of my other colleagues who retired years ago, Dr. Jones. I think he was like the fifth person that was certified in the early 60s with the gamma knife.
Mm-hmm.
He went to University of Miami. Anyway, he was telling me some fascinating stories of that nature. Have you seen some advancements? I know you're not practicing radiation oncology anymore. We'll talk a little bit what you're doing right now, but I really want to understand from your perspective, from the traditional aspect, because, we talked to a lot of patients about you should not abandon certain therapies. And what is your opinion right now on radiation? Because I know a lot of patients are scared to do radiation. They think it's going to bounce everywhere. I believe it's a little more precision, right? Am I correct in that?
Absolutely. As I see my role is, we talk a lot about repurposed drugs, lifestyle, supplements, but I also see myself as a sounding board. So people come and say, they're talking about this or talking about that. Having sat through and conducted thousands of tumor boards, you get a sense of, the standard of care that really works well and it has a low side effect profile, a good ROI, so to speak. And then you get a sense of the ones that are more marginal in their benefit, where you really need to, be careful on how to make that decision. Radiation has gone from a kind of a blunt tool to that, treated the tumor zone with a lot of, casualties of other organs in the neighboring area, a lot of collateral damage maybe, to a very, directed approach. And it's because of the change in technology. I mean, they can more or less, you mentioned gamma knife or, stereotactic radiosurgery or SBRT. These tools allow you to more or less treat something the size of a nickel, and by the perimeter of like a $50 have virtually 50% or less of the dose. So you can really pinpoint the treatment. Now, if you got a situation where you have a smattering of tumor all through the abdomen, like we see a lot with pancreatic cancer, ovarian cancer, colorectal cancer, you can't really spot those little studded areas on the omentum. So we still need systemic therapies, targeted therapies, and so far surgical therapies. But radiation is not the beast it used to be. It's very precision.
Yeah, that's very exciting news, of course, because we at our clinic at Rethink My Health is sponsored by Progressive Medical. For our first-time listeners, at our clinic, we're functional integrative practitioners, and we're always encouraging our patients to look at both approaches, because our job is to help the patient's immune function, talk about lifestyle, medication, and so the body becomes resilient. And this way they can go to some of these conventional therapies. But a lot of patients are concerned about the side effects. So you've seen an impact on the precision with less side effects, depending, of course, on the cancer itself.
Yeah. Oh, yeah. And like yesterday, I saw probably 8 patients. We work virtually and see people from all over the country. And there was, a gal with progressive colorectal cancer with pelvic masses. And, she was really working through a, medical oncologist. And, a lot of times we all get in these sort of tunnel vision. If you're a surgeon, you think surgical first, oncologist, you think, chemotherapy, targeted therapies, maybe immunotherapies. And then a radiation oncologist may have a different approach. And, she had already reached a threshold of serious toxicity. And I said, ask your oncologist for a radiation oncology referral. You got 8 centimeter mass in your pelvic sidewall. That's an easy target if it's not, a budding, some major loop of bowel or something. So sometimes we can, at least I feel part of my job is to help people ask good questions. And, we layer on a lot of what we do on top of standard of care. So I'm usually, talking people back into considering the best standard of care. I mean, the classic is women with breast cancer who have hormone positive disease, maybe HER2 positive, and they've sort of shunned traditional therapy and they're progressing, and you want them to reestablish and consider standard of care because it works, and so I sit on both sides of the fence, let's say.
Yeah, no, I think it's very well rounded, Dr. Meakin. So that's one of the reasons I want to interview you, because obviously you have to look at the best of every modality. And that patient, they have so many decisions to make. It could be the paralysis of analysis. There's just too many decisions out there. And you kind of need a quarterback to help guide them so they can make a decision that they feel comfortable with. Since we're talking about precision radiation, I want to move on just a moment. But I do want to ask you a question. If you do have an opinion on, I've been reading a lot and we've been looking at some devices, local hyperthermia. Any opinion on that?
Yeah. So it's amazing how things, reemerge over time. When I was in residency at Stanford, there were 3 or 4 universities that were really active in hyperthermia, heating body regions, combining it with chemotherapy or radiation to, acquire that synergy of the two. Heat blocks, repopulation and radiation injury repair in tumors, and also kills tumors directly. So it was regional hyperthermia, on chest walls, on neck areas.
What type of degree was that? Was that like close to 105, 104? Do you remember?
Yeah. So the goal was always to get the tumor to 104 and then make sure we had thermoprobes in and make sure that we hit those marks, but also monitor the periphery. It was tough therapy. People had to keep catheters in, and when you're putting these catheters in, you're putting them in each time. So it ultimately, it was very effective in the arenas we were treating it. It was usually, ultrasound and microwave generated. And then the billing fell out. And so it kind of dried up. There was some, research that went on, and I did it in the early years of my practice in Cincinnati. And started a center. But
were you seeing good results with that?
Yeah. I mean, things that I look back on, but it's now reemerging. There's a lot of work in Germany. One of our, there's a wonderful center in Santa Monica where they're doing, they now have technology where you can focus ultrasound to heat, deeper organs. It's kind of work intensive. I think it still gets paid for if you combine it with chemo or radiation. There's, options for that, but it's not really, there's not too much of it that goes on in the US.
Yeah, it's interesting you say that, because one of our colleagues went to a seminar and they had a company called Thermofield, and it's basically, they're going for approval. So it's off-label use, non-standard care, but it's in conjunction with other therapies, whether it's traditional or some type of integrative. And they're predominantly done research on breast And depending on the size of the patient, of course, that it can only penetrate so far, whatever that's the dermis or a little further than that. Prostate, liver, and breast that they were predominantly working on, and they were getting really good results. I had a couple colleagues, so we were thinking about bringing that on. I just want to get your opinion. I find hypothermia fascinating because I've been reading some of the studies in Germany as well. It just makes logical sense to me. I don't think any of these therapies are standalone. I think that you need to use them in conjunction, use them responsibly, and always talk to patients and how to protect themselves. And I think it's great. So
yeah, I mean, the point you said earlier, people are inundated with so many options, and like our partner at Meakin metaboliccare.com is healnavigator.com, and they are experts. They've kicked the tires of all the centers around the world, many in Germany, France, Turkey, Mexico, Caribbean, and tried to verify and clarify what's valid and what's a little more entrepreneurial and maybe not so good. And so it's nice working with them when people are in a spot where they really need some new options that aren't available in the US. They are a very legitimate team to help discern that. Like we had a seminar, not a seminar, but a webinar with the head of this German program 2 weeks ago. And so I jumped in on it, and it's more precision medicine than hyperbaric stuff, or hyperthermia, excuse me. But it was real interesting to see what they have more license to do different things. For instance, they were going to use like 3 immunotherapies at the same time, where here you couldn't stack it like that.
That's interesting, stacking. I actually see the merit in stacking. I know right now at our clinic, we've been stacking certain therapies. We've been stacking something called hydrogen inhalation. There's been some good research. We've been doing some PEMF, pulse electromagnetic frequency. We're doing something called EWATS, exercise with oxygen, oxygenating the body. And we like to kind of stack things with patients, of course, depending on their resilience and their vitality. You don't want to overdo certain things, of course, but I'm a big believer in stacking.
Yeah.
But I've never heard somebody stacking 3 immunotherapies. That's interesting.
Yeah. So that's kind of what, we try to be experts in at Meakin Metabolic Care. Like right behind me is a hyperbaric chamber, and got a sauna over here. I have a vibratory platform here. I have numerous other things around where I live. I try to have, personal experience with, everything you mentioned, PEMF, red light, sauna, infrared. And we have a team that kind of does sort of a deep dive on, the cancer impacts of all those. And I always say, we want to major in the majors. You know this because you see this situation. If you see somebody and they're looking for, to start hyperbaric oxygen or one of these more inexpensive or high dose vitamin C that are time consuming and expensive, I first say, all right, are you sleeping well? Are you getting some movement, some exercise? Tell me about your diet. Are you, we usually recommend a modified ketogenic diet, and we have a chef that helps teach people that, and we refer to great nutritionists that are really dialed in on this, many of which Miriam Kalamian, Martha Tettelhorn, Amanda King. And then also we look at, core drivers of chronic disease, and we try to rewrite the ship more or less. We look at their inflammatory drivers, their insulin sensitivities, and different measures of that, methylation pattern, and all organ function, vitamin D levels. We do a pheno-age calculation, so we kind of know if their labs are reflecting someone their biologic age or their calendar age. And then we try to make those changes or suggestions before we go a mile deep, because we are trying to be very thoughtful about people's expenditure, and we can do that deep dive, for a few $100s. And then from there, we, depending on their situation, we discussed deploying things like that. Like yesterday, I had a fellow that we had recurrent colorectal cancer, and he had done a really good job on lifestyle and repurposed drugs and chemo, but he was doing hyperbaric oxygen. He actually had a unit that was only got to 1.5. So he did a deep dive. We worked with him, and ultimately, I mean, this guy has means, so he got a steel chamber, a medical grade chamber in his house, and now he's using 2.0 atmosphere. He's stacking some things with.
Are you finding 2.0 better than 1.5? I mean, there's been some conflicting information depending on the cancer.
Yeah. So, I mean, everybody says you kind of got to get to 1.5. There's not like a lot of, hard data on the different levels beyond that. In this guy's case, his Signatera test that measures tumor DNA fragments, took a nosedive. The CEA got remarkably better. So for him, it made a difference. He also started some new repurposed drugs. He also did the Astron review, which just a quick snippet on this. Astron is a new company, about a year old, in London. And it's sort of the outgrowth of some of the partners I used to work with at Care Oncology, which I kind of started with in 2019, repurposed drugs, virtual care, so forth. They now take people's genomic reports, meaning, the mutational pattern of the tumor and how it's different from normal cells in your body. Usually companies in the US that do this are like Foundation One, Caris, Tempus, Boston Gene.
I'm familiar with Caris Sciences. I'm not familiar with that one. So that's the Astron report.
Yeah. So they look at all the mutations in the published data that nobody wanted to look at, that shows how repurposed drugs or supplements can neutralize some of those mutations. Now, some of those mutations may be silent. So the best is if they can see a outcome of those mutations through.
Yeah, that's good. That's definitely precision, and as well I do. It's blocking those circulating tumor cells, and hopefully the body gets into apoptosis, which is natural cellular death, is what we want. We both want. For those first-time listeners, thank you. This is Rethink My Health Radio show, sponsored by Progressive Medical. I'm interviewing board-certified oncologist, Dr. Charles Meakin Metabolic. Dr. Meakin, we got just a couple of minutes before the break. Let's just jump right in. And I really appreciate you talking about your background. I can talk to you, and I can talk hours each day about this stuff, because it's our passion, helping our patients and helping our society really battle a very serious disease, right? There's no simple answer to this. It's very complex, of course, very individualized. But let's just jump right into this. Repurposed medications is going to be our topic for the rest of the show. What exactly is that? Give us a very quick definition.
Yeah. So, in the pharmacopoeia in the US, they say about 1/4 to 1/3 of the prescriptions of these vast array of drugs are for things that the FDA didn't initially approve for. And the classic example would have been like something like Viagra. It was initially a pulmonary hypertension medicine that got rerouted for, aiding blood flow all around the body. And so these off-label uses are perfectly accepted and reasonable. And so over time, certain side effects of commonly used drugs were identified, and sometimes those side effects are good effects. My first sort of awareness of this was probably in the 90s, when a paper came out from MD Anderson that showed that, and they were using chemotherapy up front to try to shrink breast tumors to make them amenable to a lumpectomy versus a mastectomy. And of course, that's pretty common today, but back then it was a novel approach. What they found was people who happened to be on metformin, which normally you would think they would do worse because they probably have diabetes, actually had twice the complete response rate, where tumor completely resolved when they ultimately did the surgery, than those who weren't on metformin. And so that triggered, curiosity and interest. Other studies, there's a lot, but another one might have been people who had stomach cancer who happened to be on an old acid blocking medicine, Tegament, or it's also called cimetidine, had a much longer survival than those who weren't on that. And so, these sort of were provocative. And what really kind of drilled it home for me, it was maybe in 2017, 18, I was at a conference for sort of alternative strategies for cancer. And now one of my good friends, Travis Christofferson, who wrote the book Tripping Over the Truth. He was, working for this new company out of England, Care Oncology. And he, had a publication, or it's ultimately a publication, but a presentation where 97 patients in the London area with glioblastoma, one of the more stubborn.
Dr. Meakin, I hate to cut you off. We only got about 15 seconds. Hey, this is Rethink My Health Radio Show podcast. We're going to be back in a moment, and we're going to pick up this conversation with Dr. Charles Meakin, talking about an amazing subject, repurposed medications. Is it right for you? Keep listening. We'll be back in a moment. Okay, we're back. Welcome back. Welcome back. This is Rethink My Health Radio Show podcast. What an exciting show. We're talking about a serious disease, cancer. For those of you who listened to us for the past several months talking about cancer, interviewing patients with cancer, our approach is a rational approach. We're looking at a functional integrative medicine. We're looking to get to the root cause, and we're looking for the best of the best, whether that's traditional medicine, whether that's natural, lifestyle. The bottom line is there has to be some scientific basis behind it. And today we're talking to an expert, a physician who's dedicated his life to helping patients with cancer, who's seen it from all the way from traditional all the way to functional integrative medicine. And I want to really focus the rest of our interview on this repurposed medications, because I think it's fascinating that Americans now have the ability to combat cancer from multiple directions. Dr. Charles Meakin, thank you so much. Let's continue the conversation. Before our break, we're talking a little bit about the definition of repurposed drugs and how you get involved in it. So let's just go right back into that, because I think it's fascinating. You mentioned Tagamet, which I think is fantastic as well. I just want to say that there's a lot of individuals out there that just want to do completely natural. And once again, I respect anybody's decision. Our job is to help patients navigate through all of the information. And there's so much information out there, it can really be confusing at times. But I have to say that it's important not to abandon certain medications. That's why I believe integrative medicine is just good medicine, regardless if it's natural supplements, and there's certain medications. And I just wanted to get that opinion out there.
We were just talking about how I got into repurposed drugs. And I think the turning point was hearing this presentation of 97 patients with glioblastoma, and everyone was biopsy proven GBM. There were no sort of lower grade ones, and they were given the best standard of care at the time in the London area, probably not as good as what's done today. And they took 4 simple drugs for some window of time around the time of the diagnosis. It wasn't even a good group. About, I think if I remember, about a fourth of the patients only got a biopsy. So they really didn't have the major benefit of a resection. And it virtually doubled to tripled the median survival of that group. And so, having treated glioblastoma for years at that point, when I started as an oncologist in 1989, I was sort of like, there is a lot of juice here. I need to dive into it. So ultimately, Travis Christofferson and I became friends, and we helped roll out care oncology in the U.S. It solved a lot of the pain points in care. It was virtual. It was low cost. It was, the whole family could jump on and support people without leaving their homes or taking a day off work. And we had sort of the menu of core repurposed drugs that had good safety profiles. In fact, that's one of the beauties of repurposed drugs. Many of these drugs have been around for a long time. So unlike new drugs or untested supplements, these have wonderful, well-established safety profiles. And so, and most drugs have, 4 to 6, cellular pathways of activity. So we can kind of use them where they're generally under the radar screen or under the level where they cause side effects, but they still stress the metabolism of cancer cells. And so the list is quite long. We have, 50 in the list that have different pathway impacts. We have some core 5 ones we start and then see how people do. And it's all based on, what they're getting.
Let's talk about the core. Let's talk about the core 5. So I know metformin is one of them. That's been improved for type 2 diabetes, but it helps with AMK. And it's been studied for years and years and years. There's a lot of longevity doctors using it as well. I think it's wonderful. What are you usually starting patients on? 500 milligrams BID or QD?
We usually use 750 extended release.
Standard release 750?
Yeah, the extended release. So that minimizes some of the potential risk of dysentery, diarrhea. We like to keep the pill count as low as possible because between supplements and pills and standard of care, we like the once-a-day dosing. We start also with a statin of some sort, which, has gotten a little bit of a black eye. But as we know, I think Pericles said, the poison is in the dose. So it's all about getting that dose right in that sweet spot.
And that's because of the fatty acid component where cancer cells could be fed off.
Yeah, they work in this malevolic pathway, but they also, like metformin, they downregulate our green light for cellular division, the mTOR pathway, and they upregulate this AMPK pathway, which sort of simulates a pharmaceutical level of fasting in the body. So then you combine that with, modified ketogenic diet, intermittent fasting, some exercise, some supplements. So you're really putting the screws on.
You're really dialing it into that fasting state and basically getting into the body to be in apoptosis, natural cellular death is what we want, right?
Yeah. Otto Warburg identified, before World War II, that cancer cells primarily use glucose in the presence of oxygen to make energy. It's really inefficient. It generates a lot of lactate, a lot of cellular acidity in the environment. It's sloppy, energy use. And because you make only a few ATP for each glucose molecule, whereas if we use mitochondria to make energy, it's much more efficient. I think 32 ATP per glucose. And so by putting people in by stressing glycolysis, our normal cells do fine because that's the sweet spot for them. Once you adapt to it, many of us have sort of drifted into a glucose, sugar burning mindset. But once you adapt, just being in that mindset stresses cancer cells. Now, we feel that, that is the biggest driver of cellular cancer cell metabolism. Of course, there are some amino acids, some protein building blocks that are also a concern. There's also some, published data on cancer cells can use certain fatty acids, but the biggest one is the glucose.
Glucose and obviously there's been some studies with glutamine as well, and we're concerned about mTOR pathways. So you've got a statin drug, metformin, Tagamet, and what are the other two?
So Tagamet isn't in our first line. It's a kind of a burden to the liver. It's heavy on the liver use, and so we also use doxycycline. And people say, well, that's kind of crazy. It's an old antibiotic. Well, there's a big research drive in England. I'm going to take it to clinical. They're taking it to clinical trial. It's probably spent $500 million on it. Doxycycline, an old antibiotic, but it works against atypical things. It works to disrupt the mitochondria of cancer cells. It also can corrupt the protein mechanism in cells, so it can destabilize non-dividing cells, which is, a new target because standard of care has more trouble with that, like cancer stem cells.
Right.
Doxy, we try to slide under the the level where side effects are. It's an inexpensive, cheap drug with low side effect profile. It's also an antibiotic that doesn't knock out the gut biome like some of the heavier ones. It's absorbed in the upper.
Right. So you can balance that out by replacing it as well.
Yeah, and then we use mebendazole, an anti-parasite drug. We have to get that compounded to get it, at a price point that isn't crazy, and also at the dose that is appropriate. It's not well absorbed in the GI tract, so the Walgreens CVS dose of 100 milligrams, which is $300 or so per tab, we get it compounded and start with 300 and go up from there. It works similar to some chemotherapies like Taxol. It binds up the microtubules that sort of lock up the division step that keeps that DNA from making daughter cells. It also has some mild competitive inhibition with the uptake of glutamine. It has many other pathways that it works on, and it's really well tolerated. It's what I used to call the invisible drug until the other invisible drug came up, ivermectin, another anti-parasite drug, but a drug that is really well tolerated. And we also get it compounded because we're using much higher doses than the 3 milligram tablets sold at
the
Stromacol. And so ivermectin is being studied in a clinical trial, as similar to mebendazole being taken to clinical trial. Ivermectin primarily works to restore normal cell cycle to cancer cells. It sort of reestablishes sort of that off switch where cancer cells maybe stay immortal and cause problems because of that. Normal cells kind of say, my warranty's up, I'm done. Let's break down and decompose. So it helps cells return to that. And then there's also maybe eight or so other sub pathways. So those are the starting five: metformin, a statin, a doxycycline, mebendazole, and ivermectin, and we sort of customize that to the 100-pound gal with stage 4 breast cancer, to the 150-pound gal with stage 1. We're doing some prevention stuff on. It would really reduce the doses to the stage 4 300-pound guy. And so, but everybody gets an intake where we first try to, like you do, I know, correct the fundamentals.
Absolutely, I agree. This is exciting. With all your experience in oncology, how did we get here? Because, a lot of oncologists, some of your colleagues, it takes them several years to catch up to this. Do you actually see this as the beginning of the change? Because we definitely need some change in our medical community right now. We need some change. Right? I'm talking positive change. I'm not trying to be critical because it takes a while to evolve. But I do believe that there's some traction here from a scientific perspective. Would you agree with that?
Yes.
That's exciting, actually.
When I started in 2018, I was an outlier of the outlier. Now, I was at a point in my career where I'm like, well, if I lose my license and I'm ostracized for some reason, I'm good. I'll go do something else. I'm kind of a serial entrepreneur like yourself, but it's gained traction. The whole ketogenic diet, the athletes that are using ketosis, the integrative oncology working group, wonderful organization. It's free to join. You have to give a talk to be a full-time member. I did that a few years ago with 2 other wonderful docs that are, getting into repurposed drugs. That group went from a good 20 or 40 on a Sunday afternoon to listen to a lecture to many hundreds, with many big universities participating, doctors from those universities.
Where are they based out of, Dr. Meakin, Integrative Oncology Group?
It's a virtual group started by Manoj Reddy, lovely guy. He's a radiation oncologist in Texas. He just did it as a side project. I actually talked to him last week. I said, Manoj, you could charge $100 a year, $200. We would all stay. You got a great program here. He gets really good speakers on all the topics. the alternative, and the standard of care. Very, very well done. And then, so I see traction, and this Astron, where they now can sort of connect the dots between the various mutations and publish data on repurposed drugs. And so I see an evolution where metabolic oncology becomes maybe the fourth leg in the table of cancer care, surgical oncology, radiation oncology, medical oncology, and now metabolic oncology.
I like it. I think that has some traction, and I do believe that it's going to. Hopefully, they'll be teaching that in medical schools in the next decade or so. That would be the game changer, right?
Yeah. Well, there's, I think, 2 med schools that have an integrative oncology type. One's Tucson, and there's another one I'm blanking on. But so it's exciting. We work with like Heal Navigator has probably 8 integrative oncology nurses who sort of been through the gauntlet of working in different arenas, and now we feel like we'll help people align to do what they truly want to do, help people with tools, knowing both sides of the fence, in sort of a supportive way. We are, we're kind of mission based more or less. But I was going to mention that, in the turning point, metabolic oncology was front and center until some of the genes as drivers of cancer were first looked at and so in like 1972, when Nixon declared the war on cancer and said we're going to stamp this out in the next 10 years, ironically, Ed Kennedy was on the table there, and he ultimately died of a glioblastoma. But, the cancer rates have all gone up. They're hitting, when I was growing up, I didn't know anybody under 70 that got cancer, and there was only a few then. Smoking was more common, of course. But so at that point, there was a big shift in the research that focused on, genetic targets, the somatic mutation theory of cancer, and sort of thinking about how cancer cells acquire and use energy became sort of pushed to the side. And so now it's come back full circle in the last 10 years. And so I see, dual theories is sort of important. Yes, a lot of our repurposed drugs actually affect mutational pathways, many of which lead into energetics of cancer cells. So
yeah, absolutely. This is all positive stuff, and I understand that everything takes time. And it's interesting you mentioned President Nixon, because I've talked that a lot in my lectures, talking about. And why do I say that? Because back in 1972, when President Nixon had his inaugural speech for his second term, he basically declared war, because at that time, 1 in 7 Americans were getting cancer, and that was a lot back then. Now it's 1 in 3. For women and 1 in 2 in men, and soon to be 1 in 2 in men, of course, obviously, because I think prostate cancers could be very prevalent as we age. But those are staggering numbers. So listen, I know cancer is a multifactorial disease. I don't want to put you in a spot here, but give me your opinion, just your opinion on why do you think that cancer is on the rise?
I think it's you're right. It is. My son is in his 30s, and my daughter in her late 20s. They have friends that have had cancer. I never had that.
Neither did I.
And I was kind of in the field, so I was kind of maybe more likely to notice it. And I think it's a multifactorial issue where, number one, our diet has become adulterated. We've shifted to more of a carbohydrate-based diet, which hopefully the reversal of the food pyramid will help. We've also live in a pretty toxic environment. The microplastics that we cook with and eat with, and that are in our water and in our fish that we eat. The stress. I think social media is corrupted some of our diurnal rhythm and our normal sleep patterns. You could debate whether certain vaccines have created an immunologic environment where the body is so distracted by dealing with spike proteins that it isn't paying attention with our T cell mediated immunity to suppress early aberrant cells. And so, once again, it's multifactorial, but it's the big inflection point that you can't ignore is that since the pandemic, and of course, metabolic health got worse during that instead of better. We had a potential platform to really clean up some stuff, but we went the other way. Since then, the spike in a lot of adenocarcinomas of the GI tract, primarily colon, but also pancreatic, gastric, biliary, it's staggering. My colon cancer patients, first of all, they present more so with stage 4. And, there's always a backstory that possibly somebody ignored their complaints of change in bowel habits or.
It is shocking, Dr. Meakin, how many patients that are calling our office that are in their 30s with stage 4 colorectal cancer. It's just shocking to me. It's shocking to me.
Yeah.
And we just recently heard of a patient that lost her battle. She was like 35 years old. It's shocking to me. And it came so quickly, by the way. It just happened. And I agree with you. Maybe they ignored their symptoms. Maybe it's a combination. I align with your philosophy 100%. I'm not just saying it because you're being interviewed today. I've talked about this many, many times. It's multifactorial. We got to really look at it. Is it a combination? And we got to go back to some common sense. But here we are. What do we do? How do we help these patients navigate so they have a chance to not only survive, but thrive? And that's why I think it's so important to talk about these repurposed drugs. Hey, if you're listening to us for the first time, Rethink My Health podcast radio shows about health and education, sponsored by Progressive Medical. This is an exciting topic. We're going to have Dr. Meakin on more. If you want to get a hold of Dr. Meakin, he is available for consult. He does have a license in 45 states, which is that in itself, Dr. Meakin, is a major accomplishment. But
it's a lot of house.
And for a consultation as well. And he's not only going to talk about repurposed drugs, but he's going to talk about everything that we believe in at Progressive Medical. We believe in root cause. We believe in talk about lifestyle. We talk about all kinds of things. And I'm glad to hear that you practice what you preach, because I'm the same way. Oxygen, infrared, clean diet, and just looking on helping. But, before I get your opinion on a couple other therapies, we talked about disrupting the immune function. It's kind of interesting because I do believe immunotherapy is one of the greatest discoveries that we've had so far in traditional oncology. Okay. Because obviously before, what do we have? We just had radiation, surgery, chemotherapy. There were some modifications. You and I talked about precision radiation is better, but there really wasn't any other discoveries besides that. And when President Nixon declared war, I believe he gave $500 million in research. Now it's like, how many billions of dollars of research, right? It's ongoing. And I'm glad, I hope that we can allocate more funding to repurposed drugs and really make metabolic oncology on the forefront. Because I like what you just said. Surgery, traditional chemotherapy, radiation, and then this could probably be the fourth one. I think that'd be great.
Yeah. Oh, yeah. Yeah. So immunotherapy is pretty exciting. We actually just yesterday, we're always making educational material, and with a lot of the tools out there, you can do a lot. And so we create a kind of a semi-white paper, a blog, or a review on it. And then we turn it into an infographic so you can just see it all in one picture. We also make a sort of podcast format out of it. We also make a video whiteboard out of it. And so on immunotherapy, it's really changed some of the therapies or some of the timelines of survival for stage 4 lung cancer, especially.
I agree. Hey, Dr. Meakin, we only got about a minute and a half left, and I wanted to make sure that you let our audience know how they can get in contact with your office. What's your website?
We're out there. We don't do a lot of crazy social media stuff. I also have some wonderful teammates now that are working more in prevention, but it's meakinmetaboliccare.com. meakinmetaboliccare.com. I used to have the website coachitforwardchuck.com. I still have it. That was sort of my free coaching that I did before I, started the business of repurposed drugs. We also partner with healnavigator.com. They do all our navigation, nursing navigation when we have that, both of those involved. And then we finally, Astron.health is a tool we use a lot of. We're kind of the United States, sort of provider of that, since they can't really provide healthcare from London.
Dr. Meakin, I want to thank you so much. We only got a few minutes. Hey, this is Rethink My Health. Thank you guys for listening. It's been a great educational show talking about cancer. And if you're battling cancer right now, take a step back, rethink what you're doing. There's a lot of information out there, and we're here to help you out. We're so excited about that. This is Dr. Gez Agolli. Thank you so much. And remember, a cheerful heart is good medicine, but a crushed spirit dries the bones. Be cheerful. God bless you guys. I'm going to see you next time here on Rethink My Health.